Yeah, you can start.
Assalamu alaikum. Good morning, everyone. Today we'll be talking about an important topic, which is corneal tomography. We'll be discussing an overview of corneal tomography. I hope you will find this colorful lecture beneficial, inshallah. Some background and clinical uses, some terminology, most commonly used tomographic maps, and systemic approach to interpreting pentacam. Corneal tomography is the method by which the corneal shape, curvature, power, and irregularities are measured. Most commonly used clinical uses is screening and monitoring progression of corneal ectatic disease such as keratoconus, in post-surgery astigmatism such as post-cataract surgery or post-keratoplasty. It is also useful in planning surgery in cases of corneal astigmatism. Examples include corneal relaxing incisions such as limbal relaxing incisions and astigmatic keratotomy. It also measures the effect of corneal and ocular surface disorders such as pterygium, limbal dermoids, corneal scars, degenerations, and it has also other uses such as contact lens fitting, incision placement, and intrastromal ring placement in keratoconus, monitoring of ocular versus corneal waveform. Does anyone know any other uses for topography other than the mentioned uses? Can be used also in IOL calculation, patient selection in refractive surgery, corneal procedures, rings, and multifocal IOL, toric IOLs, and ICLs as well. Now, what is the difference between corneal topography and corneal tomography? We usually use the term corneal topography. Corneal topography is an old term used only to describe the anterior corneal surface. It is applied to the maps produced by Placido disc-based machines and consisting of anterior sagittal and anterior tangential curvature maps only. It evaluates the cornea based on the reflection of concentric rings or Myers. Examples are Orbiscan, Atlas, Nidec. Now coming to the corneal tomography, it is a relatively new term and broader term used to describe the features of both anterior and posterior corneal surfaces and the matter in between. So it creates a 3D map of the cornea. It is generated by rotating Scheimpflug imaging or camera that captures the cross sections of the cornea. Examples are Pentacam, Galili, and Ceres. Now, the most commonly used tomographic maps are this 4 refractive map display, which has the patient identification data. It has the patient's name, ID number, date of birth. It shows the eye examined, right or left eye, exam date and time. Then we have the detailed display box, which has corneal front box and corneal back. We have also the pupil parameters, corneal thickness parameters, and the XY coordinate. And the last box, which shows the anterior chamber volume, AC depth, and other parameters. Now coming to the 4 maps, which are anterior sagittal curvature map, anterior elevation, posterior elevation, and thickness map. Sagittal curvature map is a color-coded map. Now, every map we will discuss, we have 2 things to look for, which is the shape and parameters. Sagittal curvature map is a color-coded map which represents the curvature and dioptric value of different spots across the cornea. The hotter color, red and orange, represent steep areas, while cool colors, blue and green, represent flat areas. Now, as we mentioned, we will look for the shape and pattern. Normally, the shape is regular. In regular astigmatism is symmetric bow tie, whether it's with the rule, against the rule, or oblique astigmatism. The sagittal curvature map picks up corneal irregularities or hotspots that have abnormal keratometry readings. Now, the parameter, we will look to into the K readings. We will compare the symmetry of opposite numbers within the 5 mm central zone. The keratometry reading normally should be less than 47.2. 47.2 to 50 is suspicious or intermediate risk. More than 50 is high risk or abnormal. We'll also look to the superior-inferior difference, which is normally less than 2.5 diopters, and inferior-superior difference should be less than 1.5 diopters. These are some of the patterns that you might encounter in the sagittal curvature map. can be categorized into 4 groups. The first group, or group A, is normal if the K readings are normal. It can be round, oval, or symmetric bow tie with no skewing. Group B is asymmetric shapes, such as superior steepening, asymmetric bow tie with superior steepening, inferior steepening, or asymmetric bow tie with inferior steepening. Now, group C is skewed axis, whether it is symmetric or asymmetric. It can be symmetric bow tie with skewed radial axis, or asymmetric bow tie with skewed radial axis. Now, if the patient has symmetric bow tie with 15 degrees skewing, or the angle is 15 degrees, do we consider it normal or abnormal? What's the?
Less than 21.
Yeah, exactly. Less than 22 is considered normal or insignificant. Now the group D, or the last group, is special shapes: butterfly, crab claw, vertical D, or irregular pattern. Group A is normal when maximum keratometry, as we mentioned, is less than 47.2 diopters. 47.2 to 50 is intermediate risk, and high risk if it was beyond 50 diopters. Symmetric bow tie can be encountered in keratoconus when K readings are abnormally high. This is why it is important to look for both pattern and number. Now, anyone knows what does the term enantiomorphism means? Have you came across this term before? I mean, as the picture shows, this the right eye and left eye. It means mirror imaging of the cornea. The left eye is a mirror image of the right eye. Coming to the next map, which is elevation map.
One eye without looking at the other eye. This is what she means. So it has to look similar. If there is any difference between the two eyes, that it raises the suspicion.
Yeah.
This is what you mean about the.
Exactly. Now, coming to the elevation maps, it compares the height at which corneal elevations and depressions deviate from a computer-generated reference sphere, which is best fit sphere or best fit toric ellipsoid. It is also color-coded. Shades of red show elevations, and shades of green and blue show depressions. Then we will look to shape and numbers. The normal shape of in the elevation map is hourglass pattern, regular hourglass. Suspicious shapes include skewed or irregular hourglass and tongue-like extension. Parameters within the central 5 millimeter. If the anterior elevation map should be less than 12 microns, and the posterior elevation, it should be less than 15 microns. Here we have the central island with non-displaced central island and regular hourglass. Down to the left, to the right, we have skewed hourglass appearance and tongue-like extension, which is abnormal. Coming to the last map of our 4 refractive maps, so the most important consideration in this map is the displacement of the thinnest location. Again, shapes and numbers. The normal shape is uniform thickness in green or concentric rings. Abnormal shapes is displacement of the cone, or the shapes that we'll discuss shortly. Parameters include the superior-inferior difference of less than 30. It should be less than 30. If it's more than this, then this is suspicious. Pachymetry apex thinnest location difference should be less than 10 microns. And Y coordinate, or the vertical displacement, should be less than minus 0.5. Now we have the Y and X axis. The more the minus means the more inferior displacement. Inter-eye difference should be less than 30 microns, so always compare with the other eye. Now we have concentric normal shape. Then we have displaced cone to the right. Then we have the down is the inverted or bell shape, which comes in pellucid macular degeneration, and the final shape is.
Could you point at an X and Y axis?
Yeah.
These are very important. Go to the XY in the table.
Yeah.
Yeah, if you can see X meaning the X axis, so right and left deviation, plus to the right minus to the left. Why is that important for us, the y-axis? Why is the superior and inferior? This is what we care if we suspect keratoconus, if you want to do refractive surgery for your patients, if you suspect any suspicious of keratoconus, you will see inferior displacement of your thinnest location, and you will find it in this table at the y-axis. This is very important to grasp. If you grasp this today, this is enough for us.
So,
yeah, Nada is asking what are the numbers. She mentioned that.
Usually in keratoconus, the cone is displaced inferiorly or inferior temporally. The more displacement, the more suspicion or the more abnormal the value is. So the value of more than minus 0.5 is suspicious. More than minus 1 is high risk.
So less than minus 0.5, this is that we consider within the normal. Maybe your eye may be less than minus 0.5. From minus 0.5 to minus 1, this is suspicious. From more than minus 1, actually, this is keratoconus. So we'll use that to prove otherwise. This is ectatic. And to prove otherwise. I will remember to rub dry eye, contact lens warpage, all of these stuff, corneal scar, before you comment on.
What do you think of this last map? Exactly. Exactly. Generalized thinning in keratoglobus. What about this display? Anyone knows what is it? What's the name of this map?
This is
Biddle-Ambrosio enhanced ectasia display. What does it do? It simplifies the interpretation of elevation and thickness maps. It displays anterior and posterior elevation data relative to a standard best fit sphere. It's calculated at an optical zone fixed at 8 millimeters. Then it performs regression analysis on changes in anterior and posterior elevation, thinnest location, thinnest point, displacement, and pachymetry progression. It generates standard deviation from the mean. Then it gathers all this information to create a new overall map reading, applying colors to represent variation from the mean. Red color represent abnormal values, at least 2.6 standard deviation from the mean or more. Yellow is suspicious, 1.6 standard deviation to 2.6 standard deviation from the mean, and white is normal. So we have here the elevation maps, then we have the corneal thickness spatial profile and percentage thickness increase. It's represented here in colors, 1.8, which is between 1.6 and 2.6, represented in yellow color, which is suspicious. Here the value is 1.2, which is represented in white, meaning normal. Now this is what happens with Biddle-Ambrosio. We have here a keratoconic cornea fitted with a best fit sphere. It takes the average of the whole readings. Now if we eliminate this extreme reading or highly abnormal reading, now it's fitted with a new best fit sphere. So this elevation is enhanced. Now if we do the same with a normal cornea, it will show no difference. This is a quick slope or within the 6 millimeter zone representing ectasia. What about this one? Can anyone tell me? What's this shape? It's written here that that's S-shaped, also representing ectasia. Here the line is flat, meaning the central corneal thickness and peripheral corneal thickness is the same, which might be...
Yeah, don't let them... The first on the left, who anybody can read it or tell us what's the concept of the Zubair? What do you think?
I think the line shows the center of the cornea and the thinnest section of the cornea. And then as you go peripherally, the thickness increases.
Exactly.
With quick decrease in the thickness, indicating ectasia.
You mean quick increase, not decrease. Remember, it's the center.
Yes.
So all of our cornea get increased from the center to the peripheral. If there is more quick than usual, this is the quick slope. This is what Dr. Nada mentioned. What about the Aziz, number 2? the one upper letter, right?
Where did this stroke or this shape?
What does this shape means? Khan, what do you think? Khaki. Anybody? Yes, yes. Which just doesn't make sense, right? Our cornea gets flatter in the center, thicker in the periphery. Why here? It started to became a little bit of thicker and thinner. This is S shape. This is the S shape because it goes like this, then go thinner. So what do you think? Which pathology goes with thinner in the periphery? Pellucid, exactly. So S shape goes with pellucid. Upper left is keratoconus because thinning and then quick thickening. 2 is thinning in the periphery. What about 3? Mm-hmm.
The peripheral and the central thickness are almost the same, so it goes with the parietal lobe.
What 4? Could you comment on that on number 4?
We have inverted shape, or it goes upward, so the thickness is getting
Thinner.
yeah, thinner in the periphery, so it goes with PMD also. Now, the best way to interpret the corneal topography is to develop a systematic approach, not to be lost in all these colors and numbers. We'll be discussing the pentacam, which we have here. This is the format display. Always start by an identification data. Identify the patient's name, ID, date of examination, and the eye to be examined. Then we'll move to the 12 points to be examined. We have the quality specification, maximum K reading or Kmax, thinnest location vertical displacement or the Y coordinate. Then we'll compare the topo astigmatism with the manifest astigmatism. We have the Q value, then the 4 refractive maps, which we have discussed, and the thickness profile, and then lastly compare both arms. These are some causes of artifacts: long lashes, trichiasis, ptosis, non-sufficient eye opening, irregularity of tear film, or poor head position. First point to be examined is the quality specification, which gives an indication of the reliability of the topography. It can be represented in white, yellow, or red. Yellow is okay, which represents good quality. Then yellow, it's better to repeat the topo. If it is in red, it should be repeated. We cannot rely on this topography. And coming to the Kmax, normally it should be less than 47.2 diopters. Between 47.2 to 50 is suspicious, as we mentioned, then more than 50 is abnormal. Thinnest location and its vertical coordinate. Thinnest location should be normally should be more than 500 microns. Between 470 to 500 microns is suspicious, and less than 470 is high risk or abnormal. To the thinnest location vertical coordinate, as we mentioned, the values are less than -0.5 is normal, -0.5 to -1 is suspicious, and more than -1 is abnormal. We always compare the topographic astigmatism with the manifest refraction. We compare both the amount of astigmatism and the axis. The amount of astigmatism difference should be less than 1 diopter, and the axis difference should be less than 15 degrees. Now coming to the Q value, or which represent the sphericity of the cornea. Normally, the normal shape of the cornea is, anyone can tell me? Correct, exactly. Which is normally -0.5. If the value is 0, it is more spherical. If it is in positive, it is more oblate. In keratoconus, the shape of the cornea will be hyperprolated, so the number will be in more minus or more than -1. Now coming to the four refractive maps again, sagittal map will look to the steep, after looking to the patterns, we'll look to the steep K. Normally it should be more than 47.2 or 48. K-max and steep K difference should be less than 1 diopter, and the skewing in the axis should be less than 22 degrees. Superior inferior difference, as we mentioned, should be less than 2.5, and inferior superior difference should be less than 1.5. Corneal astigmatism is normally less than 6 diopters. Now these are group A patterns. If the keratometry readings are within normal, then it is considered superior inferior difference. If the superior steepening is more than inferior, it should be less than 2.5. If it is inferior steepening more than superior, then the difference should be less than 1.5. Skewing in axis, as we mentioned, should be less than 22 to be considered normal. Now we have special shapes, butterfly, crab claw, and vertical D, which is abnormal. Now, anterior and posterior elevation maps using fit toric ellipsoid. If the anterior elevation is more than 12, it is considered abnormal, and posterior elevation more than 15 is considered abnormal. Thickness map shapes should be symmetric concentric shape normally. High-risk shapes, as we mentioned, include displaced cone, bill shape, and generalized thinning. Superior-inferior difference in corneal thickness within the 5 mm zone should be less than 30 microns. In the thickness map, look to the shape, thinnest location, thickness, and brachyapex difference should be brachyapex and thinnest location difference should be less than 10 microns. Superior inferior less than 30, and inter-eye difference less than 30 microns. Then look to the thickness profile, as we mentioned. Always compare both eyes, compare the keratometry reading, the patterns, and anamorphism, as we mentioned, and thinnest location. This table summarizes the high risk value and moderate risk values. And take a quick pop quiz. Can anyone interpret this map, or tell me what do you want to look for in this map, following the 12 points that we mentioned? Dr. Tafadhal.
Okay. So this is and I need to check first the data and the eye and compare the examination date. Then I'll first look at the. I need to check the quality specification first. It's the other, so proceed with caution. Beginning, I'll look at the K values. K1 is 43 and K2 is 45. 45.
So consider K readings are all within normal.
Okay, and the astigmatism is 1.9. Then I'll look at the corneal back posterior surface, and then I'll move to the brachyapex. The thinnest location is minus 0.63.
Minus 0.6.
So thinnest location is slightly inferior, and then I'll move, K-max is 47.3, which is at the edge of the normal. So I'll move to the maps, starting with the sagittal map for the anterior. The difference between the highest is 45.
46 and 42.2.
46 and
42.2.
And then I'll compare the difference between the inferior and superior. It's 46 and 42.
What about the pattern of the shape?
The pattern is looks like asymmetric both eye with slightly asymmetric with skewed deviation.
Okay.
It's around more than 25 degrees, I believe. So slightly significant. I would say it's 20 degrees since it's slightly oblique, better. And then I'll move to the elevation map and see the elevation map is the middle that's +3. And see the 5 millimeter zone, compare and see the difference among them, and see the number R2. After that, we'll move to the posterior elevation map. The button looks like tank-like pattern. Again, I want to compare the difference between the 5 millimeter zone and see the difference among the values. And look the corneal thickness map and see the thinnest location compared to the Becky apex. So the thinnest location here is.
Thinnest location is 508.
Sorry.
508.
508, and the thinnest location on the Becky apex is exactly in the center, which was 607 microns. So it's slightly inferior. The thinnest location is slightly inferior to the Becky apex of the cornea.
To the higher side. طيب, who can take this question? Same for the same topography. R3 or R4. Suppose this patient came with cataract. He's for cataract surgery, and he has 2 or 2.5 corneal astigmatism. Do you think this patient is toric IOL, and why? Based on the curvature.
Toric IOL, because the back elevation there is abnormal values, and also it has to compare
Based only on the curvature map and
following the curvature. Yeah, because of the skewing.
this is irregular, considered irregular astigmatism. That's why he's not the best candidate for toric IOL. Suppose this patient is post corneal refractive surgery.
Can you go on?
Sure.
If you notice the nasal flattening, you have to make sure this patient doesn't have pterygium or any flattening in the lesion. But still, for toric, it's a wide range. Even for irregular astigmatism, sometimes it's asymmetric, but it's oblique. The orthogonality is not usually off. You might still consider if it's very huge astigmatism a toric IOL.
It's not a contraindication.
But definitely, but yeah, just 4 segments of mentioning.
Thank you.
Yeah, for me, I agree with Dr. If it's like this, you may undercorrect your astigmatism a little bit. This is one. And second, make sure the axis of IOL master is similar to the axis of tomography. If they're off axis, that means there is a dry eye, there is something in the cornea irregularity. You will depend on which axis. So we know we depend on IOL master axis, but I mean, if there is off axis by more than 15 degrees, which one will go? And these cornea, I think this patient maybe, they will have off axis by more than 15 if you compare the IOL master with the topo axis.
And you have to repeat it anyways because the quality is nice.
Yeah. Coming to this case, if this patient had a previous corneal refractive procedure, what do you expect the refractive error to be? Dr. Said? Exactly, why? Yeah, we have central steepling, unlike this photo, which has central flattening in a myopic correction. Who can take this case?
Okay, this both of the patients. I have to confirm the patient's name, the ID number, and I'll look at the quality specification. it looks okay. Then the Q value is minus point about 46, which is within normal. Then I look at the K1, K2, Kmax. K1 is 46.
Okay.
K2 is
Sorry about the numbers. It's not clear. If you need any number, just tell me. I will.
Q2.
K2 is 58.6.
So it is considered to be steep. And the Kmax.
Kmax is 55.8.
55.
55.8.
Okay. So both of them are considered to be steep. The astigmatism is 5.3 and the axis is 116. Okay, then I look at the test location, which is 418 micrometer, and it is displaced at about minus 0.68, which is considered to be suspicious.
Okay. Correct.
Yeah, the
elevation.
okay, move to the elevation map. It looks like the corneal sagittal curvature is symmetrical or asymmetrical with the inferior steepening compared to the superior. You can read the
Sure.
central
We have for
reading.
48.0 or 8 and 54.8.
54 and 48. This is the difference between superior and inferior. So there are findings of inferior steepening that is asymmetrical compared to the superior, and it looks suspicious to me of ectatic disease.
More than 1.5.
Okay, then I'll move on to the elevation map. The anterior elevation is what are the numbers?
We have here 18, 8, 20, 11.
8, 11, still less than 12. What about the posterior?
Posterior 23, 24, 17.
So there is posterior elevation of more than 15.
What about the shape?
So this overall picture is suspicious of ectatic disease. I'll compare the thinnest location, which is within the center. However, the Q deviation or the steepest axis is inferior. So this goes more likely, for example, to carotid bones.
So the thinnest location is displaced inferior temporal.
Yeah.
What do we call this shape and elevation map?
This is the tangential line.
Yeah, temporal extension. So this is
So what's your diagnosis?
This is carotid bones.
exactly. Now coming to this topography.
Yeah, so you can see in the LCM, such as the curvature graph, there is a steep rhythmic. It's forming the crown claw shape. But I cannot see the numbers.
There is both anterior and posterior elevation, high values. Then for the thickness map, what do you look for in this
There
case?
is inferior thinning. The overall picture is like elusive version.
Exactly. We have the crab marginal degeneration, which represents inferior thinning with the area above it with steepening. كأنها حزام أو the pattern is crab claw. In this case, can someone interpret this topography?
Exactly. So in this photo, I can see this digital curvature map. There's also steepening of the cornea inferiorly and see also area of flattening superiorly. It's, close to the also the cloud appearance. Also in the elevation map, I can see increase more than 12 in the anterior elevation map and more than 15 in the posterior elevation map. There's also displacement here, classification.
Okay, so what do you think?
About this picture, I would think also about lucid.
Other little bit.
Lucid light.
Exactly. When the pattern here is looks similar to the previous case, but the thinnest location is the thinning here is paracentral. This case, the thinning here is far more inferior. This is pellucid-like keratoconus.
In keratoconus, usually the elevation, the maximum elevation, and the area of the thinnest location. However, in pellucid, the thinning usually below the maximum elevation. So remember this, pellucid below the thinning.
What about this case? Can anyone take it?
Oh. Yeah.
If you need any number, just
the first picture, the curvature picture, it's showing an area of flat in the periphery with an area of seedling in the center. The front curvature.
so we have here high case all over the cornea, higher in the center.
Yes.
So it's flatter compared to the center, but it's steep all over. Moving to the elevation map.
Okay, there is difference.
Sure. We have 29 and 22.
Okay, it's considered high, so there is an area of seedling in the front. And
Also, the values
back
here
also,
are
yes, the
more
back.
than 15.
With the generalized thinning and
Exactly.
thickness. So this is such ectasia. Let's go more with the graphical.
Exactly, correct. Thank
Just
you.
be mindful of the pictometry.
Yeah.
The
His readings here are extremely thin,
100.
200 and 300.
Just take the epithelium, just take everything exactly. This is called epikeratoblast.
Yeah.
Just take the epithelium. And this is, by the way, with this patient, you should advise the patient to wear protective glasses, like carbonic glasses. Any minor trauma may cause oblique and then you cannot close. Trust me, you will never close a cheese wiring all over, even if with the glue, cannot close.
So be cautious when examining these patients using tonopen or whatever. The patient comes with CAD, be careful touching the eye. It is really fragile cornea. So we have here a sagittal curvature map. What does it tell you?
Saeed, what do you think?
We will follow the same shape and numbers.
There is an elevated cone in the center relative to the periphery.
So the pattern is considered, is it a bow tie, oval, or abnormal shape?
It's an abnormal shape.
Yeah, we can call it irregular. We have flattening. Let's say the thickness map shows thinning with a flat case. It goes with which pathology?
Scar.
Exactly, corneal scar. Now this class topography. Who can take it?
Right. Right.
So yes, so surgically we see more steaming in the superior than the inferior.
Shape here is irregular.
Yes, irregular.
Anterior elevation, posterior elevation, values are within the normal. What do you think the patient has?
You have irregular cornea. It's your differential.
Scar.
Okay.
There is maybe pterygium thickness.
Good. What else?
My differential here is to that the patient has ptosis and the superior data is all categorized by the machine itself. I was thinking of the region as the flatter surface was the nasal, along with the increased thickness and steepening of the 90-degree axis.
Or the dry eye. Place dry eye as a differential. Contact lens warpage. Patient wearing contact lens. This is always a good differential in irregular topography, especially if you have the elevation of normal.
Does anyone?
What was your diagnosis?
The patient most probably given the location of flattening and elevation. It is most likely pterygium or other conjunctival lesion.
Could be. As Dr. Nada mentioned, when you see an incident, you suspect pterygium. However, if you what's the astigmatism induced by pterygium? Anybody know? What's the type of astigmatism? But
Against with the whole astigmatism.
okay, why with the, what do you mean by with the whole astigmatism?
So it will be so it's the region will compress the horizontal line, but steepening will be in the vertical line.
Good. Good. And this is one of the indication of pterygium surgery. If you have a patient, even a small pterygium, but it's inducing astigmatism, very visual. It's one of the indications.
You have any questions or input?
Very nice presentation. I have a question for you regarding the superior and inferior asymmetry. Why would we mention 1.5 for the inferior steep and 2.5 for the superior steep?
The usual steepening will be inferior keratoconus. It's unusual to be superiorly more steep than inferiorly. So we need more difference in case of superior steepening more than inferior.
Okay, so if you have superior steep, what's in your mind? What's the top differential in your mind?
It can be contact lens.
Yes.
Or dryness.
These are the two most important causes of superior steep. Whenever you see a patient with asymmetrical bow type, superior steep, don't tell him you are not fit for surgery. Especially if the other parameter, the thickness, the elevation are normal. Tell the patient stop wearing contact lens, and if he is not, and he has dry eye, treat him and let him come back in 3 weeks, and you will get surprised. The cornea will be back to normal. Good. Question for resident. We need Said or Said. What's better for you, to have a cornea roulette shape or to have a spheric, perfectly spheric cornea?
Roulette.
Why is that?
To allow the light to hit at one point.
Could you explain that for us? So spheric, المنطق إنه regular cornea perfectly sphere. المنطق to have better vision, right? And then this is the concept for maybe I will ask you.
The quality of vision must be affected by the secondary symptoms.
Why there will be glares and halos in perfectly sphere cornea? Do you know? Anybody knows? Yes.
Which was the
Arwa, you know.
management?
Yeah, distribution.
Yeah, but there's usually film will be seen roulette and then spheric cornea.
We draw the arrows for the rays.
Yes.
The one comes from the peripheral, it will not cross to the far posterior. It will cross slightly anterior.
So remember the Snellen refractive equation. Remember this. The more angle, the more refractive power. So the God created the cornea for us with a steeper cornea in the center. Why steeper cornea in the center? Because it's less angle, so it needs more powerful cornea to be refracted on the fovea. However, if we have similar cornea, 42 all over, the periphery of the cornea will be refracted in front of the cornea. And this is what happened with the spheric and with the oblate cornea. And the patient will have, as Mohammed mentioned, halos, glare, all of these. بالله يا ندى افتحي لنا واحدة من الإليفيشن مابس. I have a question for you. One of the clear elevation map. The map with astigmatism. The one with hourglass. The one with hourglass. From the first slide. Okay, this one is accepted. Good. So, for you, do you have a bigger one like this one? I saw in your presentation a bigger one. But anyway, that's good. Like, question for you, Nada, because this is a question, when I was R2, I was always asking myself this question, and I didn't find the answer till months later, actually. And I asked many fellows at that thing, and I didn't find the answer. And I get confused, especially with Orbis scan. I get confused. The question for you, Nada, شايف الحين الكورنيا, it's regular bow tie, right?
Yeah.
With the roll astigmatism, as Rahat explained for us. الكلر كود لو لاحظتي في الاليفيشن ماب في الفرونت والباك, it looks like flatter, صح؟
Yeah.
Because you told us blue depression.
Yes.
And the red is elevation. Why is that? Why is that? يعني أنا أتخيل if the cornea gets steep, أتخيل we'll have hot colors in the elevation map. يعني هذه ترى المفروض hot color, يعني بس for resident هذه المفروض إنها red. يعني في elevation the color should be the same. Why the color code is different? No, it's not. The machine setting, yes. The machine will set for you. Depression is blue. Elevation is red. This is the machine will set for you.
Why is it yellow in the center?
No, I mean why in elevation we have the blue. This one, the hourglass for normal cornea, always blue, meaning always depression in the normal cornea.
It's called the best sphere.
Exactly. But in the elevation, In the refractive map, the one above it.
It's not reading numbers. Not reading this one. Right,
Okay. Do you have another map here with the same hourglass? Yeah, this concept is very important. Yeah, but maybe down. Yeah, this one. Yeah, maybe here. So you can see here, this is a nice photo. You can see what I mean. In the refractive map, it looks like red, right? In the refractive map. However, it's blue colors, especially in the posterior elevation map. The answer is, and this is very important, the answer is in the cornea, the refractive map, we look at the steep cornea. So the steeper the cornea, the hotter the color. In the elevation, we look at the elevation. So if you have a steep cornea, let's say superior inferior or with low astigmatism, the cornea will be like this. So it will be depression, will be under the best-fit sphere. If you have a flat cornea, it will be elevation like this. So it's opposite. The color code of the elevation is opposite to the color code of the refractive map. Because the best-fit sphere, if you have a steep cornea goes steeper, so it will be below your best-fit sphere. And this point of confusion for the beginner, if you start looking why this color looks blue and how I got confused, which one is with the rule, which one is against the rule. So remember, in steep cornea, if the cornea has with the rule astigmatism, you'll have hourglass. With the depression is in the vertical meridian.
Thank you.
Any other question, please? Please feel free. This session is for you. If you have any question, just raise it up, please.
Fill in a post.
Okay.
I didn't get the numbers. I'll explain.
Okay. When we have here color codes and numbers, standard deviations from the mean. So if the standard deviation from the mean is 1.6 or this is considered normal. 1.6 to 2.6, this is suspicious, and beyond 2.6 is abnormal. It should be represented in red color.
So she is the difference map. So you will have two maps. The first map is the real patient map. The second map is the map after trying a new best fit sphere. And the third map is the difference map. Yeah, go back to that one.
So
This is the first, the fit sphere. This is the second,
After
the
the-
best fit sphere. The last map is the difference between these two, trying to enhance the cone. It's clear if you read it theoretically. It's clear. You cannot understand something you have never read about. The last question from my side. Go back to tomography table, or let's start the first slide.
tomography.
Yeah. So, Nada, what do you think if you use only Placido disc? What's the advantage of using Placido disc, which is the tomography?
So the corneal topography of Placido based will give only anterior curvature. So it will not give details about the posterior corneal data, elevation, and
So the irregularity of the anterior surface will be more clear with the tomography. So if you want to consider toric IOLs, if you want, multifocal IOLs, really tomography maybe is a bit superior. However, if we talk about refractive surgery, talking about ectasia, tomography is definitely better. Why?
because it gives elevation of the posterior details of the posterior surface, which is one of the earliest signs of ectasia.
This is very good. Why it's the earliest sign of ectasia?
Why does it start posterior?
Why it starts posterior? We know in pathology. What's the keratoconus pathology? Where is the first pathology appear? Say pathology. If you see the section of keratoconus, where's the pathology? Exactly, it's a break in the Bowman layer. Bowman layer is anterior. I should see in the corneal tomography or topography, I should see my pathology anterior because, as Said mentioned, it's a break in the bone layer. Why we see it only in first in posterior? Have you been asked yourself this question? Yeah, it's a time to hypothesize.
My idea now, since there is a break in the bone layers, the whole cornea pushed by the AC anteriorly, so the posterior area correlate with the broken bone layer.
Yes, very good hypothesis. However, the anterior float will be abnormal in your hypothesis, right? But as Nada mentioned, the anterior float will be normal, but the posterior float will be abnormal. صح? In your theory, it's good, I like it, but the anterior float will be normal here, so it's against your theory. Anybody? Anybody has an idea about this? This is one of the questions I was always, when I was resident, asking myself. Break in the bone layer, pathology in the posterior float. Doesn't make sense, right? Doesn't make sense for me. And I was really searching for the answer. Why? And anything in medicine, there is an answer. علمه من علمه وجهله ما جهله وما أوتيتم من العلم إلا قليلا. إذا في أحد علم لازم نعلم. عاد إذا أحد ما علم ولغة the answer. شكرا. Anybody? Tacking. So the posterior. So if you have keratoconus, there is a break in the bone layer, and we expect the change will be in the anterior float first, but it won't happen because the epithelial layer will mask the elevation. So epithelium will be thinned at that peak area. فإذا سويت topography, الابيثيليوم مسوي thickening في الthinner area وthinning في thicker area. فيسوي لك mask. والابيثيليum has a tendency to mask this for a certain level, especially in the early sign. After the early sign, it will disappear, this masking area, and it will appear in the anterior float. However, in the posterior float or posterior elevation, you don't have epithelial masking. عشان كده 5 years ago or 7 years ago, it started the idea of epithelial mapping for keratoconus. This is why epithelial mapping is starting for this concept. So the answer is because of the epithelium can mask the elevation in the early stage. However, in the posterior elevation, we don't have epithelium to mask, so it will appear red.
So there will be a thinning of the epithelium over the elevated
Over
area
the,
and thickening adjacent.
Exactly. So it will be thinner epithelium over the cone, and at the base of the cone, it will be thicker epithelium. So it will be smooth. Okay. What's the early sign of keratoconus in clinic? In a clinical exam?
There is an X-ray of the.
This is very late to refer him to me for the hour. If you see strider. Refer to Nada.
So recent sign of patient.
It's not advanced. This is extremely advanced. This is also down.
There is nerve.
Prominent corneal layer. Yeah, but it's not that specific. Just like scissoring. So irregular astigmatism. Scissoring is the first sign you look at in clinic. Don't see a keratoconus, especially a new patient, without doing the retinoscopy. Okay. We have 2 more minutes. If anybody has a question, or we can conclude.
Level of astigmatism cutoff is 6 or
Less than 6 is considered, more than 6 is considered abnormal. The difference in, or the amount of astigmatism will help in the grading of. This is one of the parameters.
and the one means the cutoff as one means the difference between manifest and
Yeah, between the manifest astigmatism and the topo astigmatism. The axis is 15 degrees difference.
But for post-aesthesia,
Sure.
what are the parameters that we should check or see that might guide that the patient is progressing?
Oh, that's a good question. Do you know the answer? For post-LASIK ectasia, he's asked.
For ectasias generally, we look for different parameters. We assess the whole metacam as we mentioned. Kmax difference of 1 diopter in 1 year. This is considered.
Yeah, it's similar to other transformers, but there is a trick in post-LASIK ectasia. Is you have to do cross-linking whenever you diagnose the ectasia, post-LASIK ectasia. Don't wait for confirmation. Patient come within 40 years of age with post-LASIK. There is ectasia, cross-link today. They will progress. They will progress. Don't deal with them like keratoconus. This is iatrogenic keratoconus or iatrogenic ectasia. Cross-link them at the day of diagnosis. Don't delay them. This is the only thing if you want to learn about post-LASIK ectasia. Apart from that, post-LASIK sometimes, especially with the old LASIK, you see a lot of irregularity. We care about the posterior elevation. You see steep, hot, especially with recurrence of refractive error, especially with astigmatism. You can know from patient situation, patient subjective refraction, decreased vision, exactly, subjective refraction, the curvature map, you will see a little bit of steepening, maybe the LASIK, the flattening, but there is some elevation or hot spot. I care about the posterior elevation. If the posterior elevation is normal, this is not ectasia, this is irregular cornea. If the posterior elevation is elevated, okay, I will consider cross-linking today or next week. I will not delay the patient. I will explain for him your vision is getting deteriorating. Let's catch that vision now. And then we can take care about vision later, either with glasses, contact lens, or ICL if the patient has high refractive error, but don't do another procedure other than cross-linking.
Tomography mentioned that limb relaxing incision based on spot. How much the limb relaxing incision clinically really correct from astigmatism? How many diopters can correct?
Can correct depending on actually. This is a good question. I don't do limb relaxing incision. I do in trifocal. If the patient has astigmatism, one diopter, it's between the toric and non-toric. What I do my phaco in the steam meridian. I do my incision of phaco exactly at the steam meridian. And once I'm done, before I remove fisco at the end of the procedure, I do another phaco incision opposite to it, 180. So it will be 2 parallel phaco incision, and it correct up to half diopter, 0.6. For limb relaxing incision, actually, there are a lot of nomogram, a lot. But the correction really, it's minor, not a lot. Maybe with the 1 diopter, I don't think it's more than that. For this reason, the toric IOL came. If the correction more than 1, toric IOL will not be utilized. But there are a lot of nomogram, depending on the patient age, depending on the patient eye, is it virgin eye or touched before. So personally, I use AK in patient with post-graft. I don't do it in virgin eye.
The question in refractive surgery assessment, how many times do you need to say that I will not go for refractive surgery? For example, if the patient has maybe 2 sides only, like superior cave disparity and Kmax like within the range of 7 to 50.
Yes.
But no other side of keratoconus. Would you?
Yeah, this is a good question. So if you have a patient like a one alarming sign, for example, but all are normal, this is a good question. First of all, rule out contact lens. Second, rule out dry eye. Okay, these are the 2 important clues to rule out. Second, look at for refraction stability. Patient glasses today, patient glasses last year, patient glasses 5 years ago. Patient age, if the patient 30-year-old age, أنا reassuring patient واحد من 18 this is history of keratoconus, family history of keratoconus, family history of LASIK or refractive surgery before. Then all of these, if the patient has only one suspicion, and the patient really needs the procedure to assess the situation with him, you can explain for the patient. Then I would wait like whether 1 year, just making sure stability. Then you can consider the procedure, and then maybe you can do cross-linking or you observe them for possible cross-linking. And the safest is not to do the procedure. if it's life-changing procedure الواحد طبعا عمره مثلا 23 سنه 24 سنه يبغى يدخل عسكري which is very common خلص جامعه ما لقى وظيفه يبغى يدخل عسكري مثلا في باله. This is life-changing. This is life-changing. If a suspicious مثل ما قلت only one alarming sign or other, you can do it with cross-linking. You can do ICL, or at the end you'll explain. But if there is family history of keratoconus, changing in the glasses, patient is younger than 21, I wouldn't touch the patients. I wouldn't. Rule out dry eye. Remember this: if you go out today with a whole message of dry eye and contact lens warpage, then irregular cornea, in patient, there is a lecture I will present in Red Sea Symposium next November about unexplained visual loss. Trust me, dry eye is one of the most important part. Always rule out the significant part, and at the end you will find dry eye, macular fingerprint epithelial dystrophy. You will find something very faint. You cannot look at it. Remember, this dry eye can cause, and the patient will explain for you. Like last week, we said, patient will say, "Doctor, I have intermittent loss of vision, but this is amaurosis fuge axis. You don't know what's going on, and the patient may fool you, So this is your." So we grasp that the dry eye is a significant pathology from vision, even it can lead to suicidal activity, especially after refractive surgery.
شكرا يا ندى. Very nice
Thank you.
presentation.
You're very